In this session, we are going to discuss here, I will be starting a new playlist under the heading of the thorax. Another region has been started here, and before starting this region, I will try to emphasize on one thing, that you have to divide this region into 4 major subregions, 4 major compartments. I can say 4 major components here, and number 1 is the thoracic wall. Now, if you see the thoracic wall, so we have to divide the thoracic wall into 2 things again. One is called the thoracic cage, and another will be the thoracic, or you can say intercostal apparatus. So, this will be it's called the intercostal apparatus. Apparatus means you have to do here the muscles, the arteries, the veins, the lymphatics and the nerves. So, you have to actually watch them. Now, in this first portion, we are going to discuss here the thoracic cage, means the osteology of the thorax or the thoracic wall, osteology on the bones related to the thoracic walls. Now, as far the thoracic walls or the thoracic cage is concerned, probably this is the region which has got the maximum number of bones, but almost every group of bones is identical to others. For example, we have got 12 pairs of ribs. We do not have to do all 12 pairs, means 24 ribs. We do not have to do, just do one typical rib, or some atypical ribs with distinguishing features you have to just look at. We have got 12 thoracic vertebrae, maximum number of vertebrae they are present in the thoracic region, but you have to do just one. This is a typical thoracic vertebra, and some other atypical you have to just see their distinguishing features only. And then we have to do here the sternum. The sternum has 3 parts here: the manubrium sterni, body of sternum, and a vesified process. So, this is something, and they are articulating with each other, forming joints supported by the ligaments, and see all these things are forming here the thoracic cage. And we have to see here in first in thoracic cage, the first structure that you would see is the sternum. Now, see the sternum, as you know here, is having 3 parts here. This is called the this occupies the central portion, anterior part of the central portion of the thoracic cage. This is called the breastbone also. So, see, this is the central portion has been occupied by this, lying in the midline, and you see here is the protecting the central, means it is much thicker than all the bones which are attached to this. These are the ribs here, the 12 ribs. So, it is thicker and stronger than this. So, it is giving a major protection here in the central part of the thoracic cavity inside, and central part of the thoracic cavity inside is called the mediastinum, and in that is lying many structures including the heart. So, this is also highly protective. It is a major part of your rib cage, which is giving attachment directly or indirectly to the ribs which are approaching it. It is also giving attachment to the muscles, being a very important part of the thoracic walls, and this is actually present here. So, sternum embryologically develops from one half from one side, one half from the other side, and they unite together here in the center to form this single structure. And if you see here, this sternum basically is a major chest bone. You see here, it is called the breastbone also, and the word has come from the Greek word is sternon. Sternon means the chest, sternum, chest bone, and it is the flat bone. By definition, you see, by classification, it is this is a flat bone. All the bones, usually all the bones which are forming or which are surrounding the cavities, or which are surrounding the cavities and joined together to form a cavity inside, just like you see cranial cavity, the calvaria, the bones of the skull which join together to form the cavity inside, that is the cranial cavity, all these are the flat bones. But the other bones which are forming the face and other things, the facial skeleton, they are irregular bones. And we have here also the sternum is a flat bone, even the ribs are the flat bones. And if you actually look at them, the ribs are either directly or indirectly joined with the sternum. And sternum has three parts here. First, this one, that is called the Manubrium sterni, which is the handle of the sternum, you can say. This middle portion, this is called the body of sternum, and the last small projected this one, this is called the xiphoid process. So, it has three parts here. Ribs are directly or indirectly attached to the sternum here. The first rib, we will tell you that the first rib through its costal cartilage directly attached here to the superolateral angle at the costal notch of the Manubrium sterni. The second rib through second costal cartilage is attached here to partly to the Manubrium sterni and partly to the sternum or the body of sternum to the lateral side. Third costal cartilage to the sternum. Fourth costal cartilage means fourth rib through costal cartilage to the sternum. Fifth also, sixth also, 7 also, but 7 partly to the lower part of the lowermost part of the sternum and partly to the xiphoid process. These ribs which actually have their own costal cartilages through which they are attached here either to the Manubrium sterni or to the sternum, these are called the true ribs. So, these will be called as the true ribs. But those ribs, the next 3 ribs means from 8, 9 and 10. So, you see that this 8, this 9 and 10, they have their costal cartilage, very large one, you see this very long costal cartilages, but these costal cartilages, they do not reach the sternum directly, but they are attached here to the costal cartilage above them, means preceding one. So, 8 will get attached here to the costal cartilage of the 7th, 9th with the costal cartilage of the 8th, 10th with the costal cartilage of the 9th. These ribs which we are actually showing you, these are called the false ribs, because they do not have direct access to the sternum, but they attach here via the costal cartilages preceding to them respectively, and they are then indirectly connected to the sternum. But other 2 ribs, the last one, this is the 10th, 11th and the 12th ribs, 11th and 12th ribs, they do not reach at all, neither directly nor indirectly, but they do not even reach anteriorly. They will stay here posteriorly, hardly laterally they will stop here, and they will be embedded within the musculature of the abdomen. These ribs are called the floating ribs. So, we have these are called the floating ribs. True ribs are called sternovertebral ribs, and these false ribs, you see that is the vertebral, we call this true ribs are called sterno, is starting from the vertebral column and going into the sternum, vertebrosternal. And if in this sternum especially, you see the 3 parts we have shown you here. The first part is this, and I am showing you here the notches here in the sternum. Is the Manubrium sterni, notches in the Manubrium sterni. You see this notch, this is called the jugular notch. I say it is called the supraesternal notch also, this one, which you can feel here at the middle of your neck in the center, where there is a small depression here. This, above that you see this is a curve, this is a little bit concave, you call it supraesternal notch or the jugular notch. On 2 sides of this jugular notch, we have got 2 other notches, one on either side. Here the clavicle is attached. This is called the clavicular notch to form the sternoclavicular joint. Sternoclavicular joint is not only this, but another notch is created here, little inferior to this. This is called a costal notch. We call the first costal notch, and that first costal notch will give attachment to the first costal cartilage. Actually, first costal cartilage and this sternal end of your clavicle, they are having the same capsule. They are making here one single joint, that is called the sternoclavicular joint. And after that, this is the lateral border of the body of the Manubrium sterni, and here again you will see here a facet, demi facet, half facet, because half will be present here in the upper part of the lateral side of your body of sternum. So, this facet is very important because at this facet is attached the second costal cartilage. Because the first costal cartilage, first ribs we cannot feel because they are under the cover of the clavicle. That is why the counting of the costal cartilages and of the ribs and of the intercostal spaces, this is in fact started from the second costal cartilage. So, this is half facet here, half facet here, demifacets here. So, from here you will start this here. So, Manubrium sterna important from this point of view. It is not just is important here, but you will see that this Manubrium sterna, its inferior costal facet, its inferior articular facet will make a joint with the superior articular facet of the sternum to form here a joint that is called the manubrio-sternal joint. And the manubrio-sternal joint is a symphysis, it is a secondary cartilaginous joint. You see manubrium, this green color is the Manubrium sterna, with having all its notches here, jugular notch, clavicular notch, first costal notch, and here will be second costal notch also, but it will be half because the remaining half will be on the body of the sternum. So, it is not just giving articulations to certain bones and the cartilages, but it is giving attachment to some muscles also. It is very protective, you see here in the upper part of the chest. And it is giving here the interior surface, upper part of the interior surface of the Manubrium sterna. It is giving attachment to a very important muscle in the neck, that is called the sternocleidomastoid muscle, a part of it, sternal part you can say, because rest will be the clavicular part that will take origin from the clavicle. So, this muscle is called the sternocleidomastoid muscle, a landmark muscle in your lateral side of your neck here, which you can feel. Not only this, but at the same time the Manubrium sterna and part of the body of the sternum, they are giving attachment to a very important muscle of your upper limb, pectoral muscle. This is called the pectus major. And at the same time you will see from inside means from the thoracic side of or from the internal aspect of the Manubrium sterna, two more muscles will take origin, and these muscles will go here to the central part of your neck here, upward here, and will get attached with the hyoid bone and thyroid cartilage. You call such muscles as infrahyoid muscles here. So, Manubrium sterna is important from these points of view. And if you see in this also, it is making here a joint. This joint is called the manubrio-sternal joint, and because the sternum, Manubrium sterna and body of sternum, they are having a movement during breathing, and this movement will be little bit angular movement, as angular movement is not more than 7 degrees, means it looks actually straight when it is stationary, but during movement you see that it will have little bit angulation. So, that posteriorly it will be little bit concave, and here is the vertebral column. So, concave means its anterior posterior diameter will be increased, and the pressure inside the cavity will be less. So, air can rush in. So, this will help in inspiration. So, you are watching this, the facets. Manubrium sterna, very important part of the sternum. We have seen here the clavicular notches, the jugular notch, and then you will see sternoclavicular joint formed here. Sternoclavicular joint is not just this, but this also. Jugular notch you are seeing in the center, and you can feel this also on your body. Sternal angle, we told you that manubrio-sternal joint, because here is a little bit angle, it is not straight here, you see. So, you are watching this. So, this angle is called the sternal angle or the angle of Loius. Very important, because a lot of landmarks anatomically they lie at this place here. You have already noted here, it is secondary cartilaginous joint, second cartilage is attached here, rib palpation and rib counting starts from here. And if you see this, that intercostal spaces are also recognized, they are also assessed from here also. So, the sternal angle important from clinical point of view also and anatomically as well. Sternal angle means manubro-sternal joints, other name you can call it the sternal angle, because here the sternal angle is located. Second part is of the sternum is the body of sternum, corpus sterni, we say body of sternum. Its other name is the gladiolus. And you know that if you are actually touching it, it is a little bit convex. You see, this is a little bit convex anteriorly, if you feel this, and concave posteriorly. Either it is having on its lateral side the facets. Facets means it was having the second facet also, but demi-facet. The third is third costal cartilage, the fourth costal cartilage, the fifth, the sixth, and the seventh. Seventh is half to the xiphoid process. Eighth, ninth, and 10th, they do not reach here because they are attached here to the costal cartilages available above them. Above them, these are because these are the three ribs which behave similarly. These are called the false ribs because they do not approach the articulate with the side of the sternum directly, but through other costal cartilages which are lying above them. Not only this, but we told you that its anterior surface is giving attachment to the pectus major along with the manubrium sterni. We call it the is called the sternocostal head, but this is not just manubrium sterni and sternum, but the pectus major will take origin from the ribs also, not ribs, cartilages. That is why we call them sternocostal head of the pectus major, though pectus major has clavicular head also, and now it is attached here to the humerus. This is important from musculature, you say from muscle attachment point of view also. Very important bone which is supporting, you see in the center, very strong here because on the back side will be part of the heart. You see the right atrium of the heart is lying just behind the sternum, and even some part of your right ventricle as well. That is why it is protecting them. And it is not just them, but it is protecting certain other viscera also, which are lying in the central part of your thoracic cavity. You call this central part of the thoracic cavity is called the mediastinum. So, if for example, the heart is lying here, if you see this is your diaphragm, if the heart is lying in this over the diaphragm, it is supported and surrounded here by pericardium, fibrous pericardium that you see in heart. And this fibrous pericardium is stabilized here by the ligaments which extend from the back of the sternum in also from the back of the manubrium sterni. This is called the sternopericardial ligaments, superior sternopericardial, and this is the inferior sternopericardial ligament also. They are also giving attachment to certain ligaments to stabilize the heart within the pericardium. So, see body of the sternum here in relation to the entire thoracic cage. Articulations you are again watching. This is a sternocostal joint, costal cartilage. This is costal cartilage number 3 because this is sternal angle and here it will be second costal cartilage. The third one you see, third part of the sternum is the xiphoid process. This is xiphoid process you are watching, and it is having a demi-facet for the 7th costal cartilage, we have already told you. So, it will have demi-facet, you see this one, and then other demi-facet is in the side of the sternum. This is for the articulation of the 7th costal cartilage, the last true rib, because after that 8, 9, 10 they are the false ribs, they are not directly approaching the side of the sternum. And here again you can say is giving attachment to the diaphragm also, because the diaphragm will be taking origin here from the bones around them, from bones around the lower part of your thoracic cavity, the available bones from anterior to posterior. So, anteriorly the first thing is the xiphoid process. So, diaphragm will take origin from xiphoid process also, and the heart is lying here, pericardium this. So, pericardium is also having attachment to the back of the xiphoid process here. This is called the sternopericardial ligaments, inferior sternopericardial ligaments, some fibers are attached to the back of the xiphoid process. Xiphoid process very important. and we will tell you that this process which you are seeing is almost pointed here, but this sometimes can be even blunt, can be pointed, and can be sometimes even bifid also like this, and it can be deviated one way or the other sometimes is. And here again a joint, this is called Xiphisternal joint that we have discussed. And this Xiphisternal joint, because in the middle, in the central, you see in the median plane anteriorly or posteriorly, all the joints they are supposed to be, this is actually wrongly supposed, but it is supposed to be secondary cartilaginous joints. Because most of the joints, because in the midline, because symphyses usually lie in the midline, so all the joints which are lying in the midline in the median plane, they are rightly or wrongly they are called the symphyses. Like you see in the mandible, if you watch the mandible, if you touch the central part of the mandible, mental or the chin here, two parts of the mandible from left and right they join here, and we think it is a joint. And the joint means it is in the median plane, that is why we call them symphyses, secondary cartilaginous joint, we call them symphyses menta, but it is not true. Here is not a symphysis actually here is no joint even. The two parts of the mandible they are fused here to form this band here, this is called the genu of mandible, or you can call it the mandible is called here this genu of mandible, but you will never call it the symphysis menta because there is no joint at all, let alone symphysis, there is no joint altogether. But here from, if you are coming here in the central part of your neck, you are coming here at the jugular notch, then you are to the interior surface of Manubrium sterni, then the joint comes. You see a ridge will come here, a thickened ridge, transverse ridge will actually come here, you feel here under the skin. This will indicate the Manubrium sternal joint has reached, and this is now a secondary cartilaginous joint, a symphysis, a very much symphysis. And then you are coming here to the body of sternum, again a joint comes. Because when the Xiphoid process comes, you see the joint is there, it is called the Xiphisternal joint, but this is not a symphysis. This is primary cartilaginous joint, this is cartilage, hyaline cartilage, and here is the bone here. You see this is synchondrosis, this is not symphysis. But after that you will come here under the abdomen, and when you reach to the symphysis bone here, in the hip bones here, two bodies of the symphysis joined together, very famous symphysis pubis, pubic symphysis. So they are lying in the midline, and behind also we will tell you later that behind, even posteriorly also, in the vertebral column is there one vertebra, another vertebra, and you will see the two vertebrae are there, and if two vertebrae, these are their articular surfaces, hyaline cartilage they have, and in the middle you have got the fibrous tissue, fibrocartilaginous disc. So what is this? Intervertebral disc, a very good example of symphysis. In the middle bigger portion being the fibrocartilaginous, fibrous, and the articular surface is covered with the hyaline cartilage, we call this joint as a joint, this is called a secondary cartilaginous joints, we call them symphysis. If for example, if you think that if this fibrous tissue would not have been formed for example and would have remained full hyaline cartilage like this, then you will call such thing as the primary cartilaginous joints, which surely is not present in the vertebral column, but this is present here, here this is present, costal cartilage, hyaline cartilage, here this is a bone, and here rib is the bone. So this is the bone, this one is the bone, in between is the hyaline cartilage, very much primary cartilaginous joint. And same is the case here, hyaline cartilage here, even some part will be bone, will get ossified here. So hyaline cartilage here, tip will be bone, okay, here is the bone, primary cartilaginous joint. In your young bones also, you have seen here, this one epiphysis, this is diaphysis, in between we have got epiphyseal plate which is a hyaline cartilage. If this is hyaline cartilage, epiphyseal plate, so here bone, hyaline cartilage, and close to the hyaline cartilage you see that is here total it is hyaline cartilage, you will call this one as primary cartilaginous joint in the young bones here, bones before the fusion of the epiphyseal plate in adults. So these are some examples of the primary cartilaginous joint. So this one is the primary cartilaginous joint also, synchondrosis, and here this is this Xiphoid process will remain, it is cartilage, but with the time it will ossify, and within 30 to 40 years you see that entire Xiphoid process will be converted into bone. Now the body of sternum in Xiphoid process will look one bone here, we do not have joint at all. This is what we call here the Ziphioid process. So, these are the parts here in the chest bone, you call them the this is breast bone portions here, you call them the sternum. As far the clinical correlates are concerned, you see very important bone in the central part of your chest, thoracic cage here. So, if you want to go for certain open surgeries in the mediastinum, especially you are approaching the heart for the open heart surgery, open cardiothoracic surgery for a coronary artery bypass, or for any operation here, you see this is the aorta is coming out of the heart, and if you see this is the arch of aorta and this is descending aorta. In the aorta, in any part of the aorta, if there is any aneurysm and you want to repair the aneurysm, open abdominal surgeries are required. You have to actually have here an incision, you have to cut the central part here, cut the longitudinally cut the sternum into two halves. This is called sternotomy, which is very important in cardiothoracic surgery, this procedure. But now minimal invasive radiologically or radiologically guided techniques have in fact limited the use or the access of this sternotomies nowadays, because if these minimal invasive surgeries are done, there will be shorter recovery time and complications are less. So, less morbidity will be there. This is called sternotomy. You see this is here, skin, superficial fascia, everything has been removed and the bone has been cut here longitudinally into two halves. This is called sternotomy, and you are seeing the fibrous pericardium. If you cut the fibrous pericardium, you will get the heart exposed. If you see sternal fractures, usually they are okay, they are rare fractures, but direct trauma due to motor vehicle accidents or high impact injuries, they will lead here to the damage here to the sternum. Especially you see this Manubrium sternum is the most commonly injured, and if this is injured, ribs can be simultaneously fractured also, and vital organs can be compromised. Another is here because it is superficial bone, you can feel this under the skin, and here outside you have the periosteum, then is the compact bone, then the spongy bone comes here. This is spongy trabecular bone, this is actually present here, and this is having a red bone marrow throughout life. So, especially this red bone marrow, you can take the sample of the red bone marrow for pathological analysis here. This is called the bone marrow biopsy. This can be accessed here, this can be extracted from either the sternum or from skull or from vertebrae or from iliac crest. And surely, rarely the skull is used and rarely the vertebral column will be used, because these are very vital nervous system organs are lying underneath them. We can use two things very easily. One is the iliac crest, which is subcutaneous, and then the sternum. So, bone marrow biopsy through this long needle you can actually recover. But when in obese and overweight person, when the iliac crest cannot be palpated, it cannot be accessed easily, sternum is very easy, and from Manubrium sterna you can actually extract it here in obese and overweight person where the iliac crest cannot be accessed. We are seeing here bone marrow biopsy in many diseases you will have to take here. So, another condition that is called the pectus. Pectus means chest, excavatum, excavatum means depressed, you see excavative, cavitated means it will be concave, this is excavatum, you see this here. This is a funnel shape, we call the funnel chest also, sunken central part of the chest. This happens in certain diseases where there is a protein, say collagen formation is congenitally defective, it is called the Marfan syndrome. There is any collagen, another defect is called the Ehlers-Danlos syndrome. These are two major syndromes which will lead to this problem. This is called pectus excavatum, this is a funnel chest. But this can be, in contrast to this can be like this also, you see, protruded outside here. Now, in the second part of this discussion, we are discussing here the thoracic vertebra. We have 12 thoracic vertebrae, and each of them they are giving articulation to its corresponding rib posteriorly, where the head of the ribs are articulating with the body of their corresponding vertebra, as well as partly from the vertebra preceding to that, above that. but the tubercle of the rib, which is articulating with the facet on the transverse process of the corresponding vertebra. So, they are making the joints, the ribs are very much in connection with the vertebrae behind and anteriorly to the sternum, directly or indirectly, except the last two ribs, which are the floating ribs. So, in the thoracic vertebra, if you look at this thoracic cage, we have already told you that thoracic vertebra, they basically are you see here. So, thoracic vertebra, above we have got the cervicals, 7 cervical, below we have got the 5 lumbars. So, we have got here 7 cervical, we have here 5 lumbars, and then we have the sacrum. So, it is sandwiched between the cervical above and the sacral say lumbar below, and each of them, they are connected with each other by means of this symphysis, that is the intervertebral disc. And if you will actually look at them, the size of the thoracic vertebra from above downward, it is increasing in size. If it is larger here, so this will be smaller, this will be larger, the next will be much larger than the previous, more larger, more likewise here the lumbar and this next second lumbar here, they are getting progressively, they are increasing, because the weight above each of them will be greater than the previous one, you see. And if you look at the thoracic vertebra, you see this is thoracic vertebra, watch it here, cervical, they are smaller, but they are increasing in size, but when they are thoracic here, they are increasing also. You see the first thoracic and you see the last thoracic, and you see lumbar also, you see the first lumbar, you see the last lumbar. So, they are increasing in size because the weight is increasing from above downward, the weight is increasing. So, they have to sustain the weight because it is weight bearing. See from behind, the thoracic vertebrae you are actually watching here, and you are seeing here that the thoracic vertebrae here, the tip of the transverse process. So, the tip of the transverse process of all vertebrae, corresponding vertebrae, they will articulate with the tubercle in the rib here. So, this is the tip of the transverse process, and you are having here the tubercle of the rib here. So, they are making here a joint. This joint is called the costotransverse joint. So, if you look at this, and if you are seeing here, this intervertebral disc, if for example you are watching here, this is body of vertebra, this is not thoracic, but this is lumbar, but it will be identical in thoracic also. This is body. In every vertebra there are 2 main portions, one is called the body, and then is the rest of the vertebra, this portion which has many landmarks here. This is called the vertebral arch, and both of them, they are connected here with each other by means of this is called the pedicle. So, we have basically 3 parts here, or you can basically 2 parts, one is called the body, another is called the vertebral arch, or you call the neural arch also, and both are connected by means of this is called the pedicle. And this body of one vertebra and the body of the next, or the body of this vertebra or the body of the preceding vertebra, they have got here a joint, they have got here a fibrocartilaginous disc in between, this is called the intervertebral disc. We have in all, because we have total 30 vertebrae. So, we should have actually 29 discs here, but we do not have 29, we have only 23 discs, in such a way that the cervical vertebrae, they are 7, they have 6 discs. We have 12 in the thoracic. At the same time, we have got we have got 5 in the lumbar. So, we have total 6, 12, 18 and 5, this makes 23 total. We have the discs like this, that structure is identical here. So, if you would actually look at them, you see intervertebral disc has been shown. We watch the structure of the intervertebral, we see the disc here, vertebra above has been removed to show you the disc, and half has been cut here to show you this articular surface, this is bone, and this half disc has been shown to you. This intervertebral disc, but watch the structure of the vertebral disc here. You see here, the disc is composed of the two main components here. So, one component that is occupying the central part. So, see this is the central part, central core of the disc is occupied by this. This is containing gelatinous substance, gel like substance. And this is called, we call it the nucleus fibrosus, we call the nucleus pulposus, not the annulus, we call the nucleus pulposus. This is called the nucleus pulposus. This is derived from the notochord. If you remember, embryologically, its derivation is coming from this is a remnant of the notochord. This is present in the central part of the intervertebral disc, but the same will be present and passing through the body of the vertebra. Then it will be passing through the central part of the next intervertebral disc. Then this is the next body of vertebra. So it will be just like a iron bar, you can say, the gelatinous bar that is continuously passing here from throughout the entire vertebral column. This has provided actually the foundation at a central axis for the arrangement of the vertebrae. This is called the nucleus pulposus. But at the same time, you see that it is not just nucleus pulposus, we have another thing also that is called annulus fibrosus. This is annulus fibrosus, means this nucleus gelatinous substance has been surrounded by the fibrous tissue all around it in form of layers. You see. This is called annular fibrous annular material. This one is called annulus fibrosus. So, disc is actually formed by this. And sometimes you see that when there is any pressure here from due to stress or overweight or here, when the pressure is from upper vertebra to this, for example, intervertebral disc, this annulus fibrosus it gets cracked. Means it is, you can say it is broken. You see, it's like this. Now, see, especially it gets you can say it gets broken, means gets cracked here, means it will get cracked here. So, here is a crack, means this is gone, means it will be like it is cracked here. When it gets cracked here, so the gel which is present inside, it is leaked from here. But through this crack, this gel gets leaked here. Just like in a toothpaste pack here, you see the toothpaste cylinder, inside is the gel, outside is the foil coating here. If you will actually break the tube, you see the gel will come out in the middle. So, the gel comes out in the middle. Actually, this is called the herniation of the disc. It is not the entire disc gets displaced here. This is a crack in the annulus fibrosus that will cause here the leakage of the gel between this cracked spot here, and this comes out here. Comes out means because it is lying there inside. You see, here is the body, here is the body, and here is lying. So, you see inside is the vertebral canal. So, this will compress the structures within the vertebral canal. The spinal cord or the nerve roots which are emerging out of the intervertebral foramen, they will be compressed here, and you will have the referred pain or you have a motor activity problem. So, this is called the herniation of the disc, herniation, slipping of the disc. This is because of the crack in the annulus fibrosus leading here to leakage of the gelatinous substance. You say leakage of the nucleus pulposus. This green color is the nucleus pulposus, and this white color is the annulus fibrosus. This is the disc and is forming here a kind of again a secondary cartilaginous joint. Now, look at this vertebra, various parts now. Any vertebra, it is not just this, but any vertebra. We told you that it has got two parts. One part is anteriorly placed, this one. This is called the body. In any vertebra, here also, but here the body, usually you see that the body is almost, you see, heart shaped. This is heart shaped and increasing in size when you are descending down to the lumbar vertebrae, because the weight is actually increasing if you are going down here. This is called the body, and the rest of it will be, you see that rest of it will be, except this portion small, rest of this which you are seeing like here, all this is called the vertebral arch, or you can call it the neural arch also. But both are connected by means of this structure, this one. These are called the pedicles. So, one thing is the body, another thing is the vertebral arch, and connecting both of them is the pedicle. So, body, you are seeing this green color. If you look at the body now, you see here, if you are looking at the body, the upper part of the body, just when the body is finishing here, in the upper part it will show you here a facet. This is the facet which is giving articulation to the similar facet on the head of the rib here. This is called superior costal facet. And above that you see that it is not just here superior costal, but similarly at the lower part of the body, when the body is finishing in inferiorly, there is another facet also, that is called the inferior costal facet. So, we have got the superior costal facet, larger one, because this will give articulation to its corresponding vertebra. If it is the fourth thoracic vertebra, it must be the fourth rib which should be attached here. If the fourth rib is attached here, so who will be attaching here? Because here you know that is lying the fifth thoracic vertebra, and here is showing you similar type of articular facet, the larger one, and here will be our fifth rib. Means if the fifth rib more than 60-70% articular say head is attached to this fifth, and the remaining 20 to 30% will be attached to the fourth here. Means this will be for the rib that is in number one rib more, you can say one rib higher. That means it will be one rib higher, means it will be in counting is one rib lower here to the fourth here. So, this will be for the fifth, 30 to 40% of the fifth, and this will be for its own corresponding, means fifth ribs here. So, this will be actually larger and smaller will be coming from the third. So, this demi facet here, so demi facets on the head, the larger one being on its own corresponding, and the smaller one, that is the upper one, that is from the preceding vertebra here. So, this is something that you are actually watching are the superior, and these are called the inferior costal facets. So, this is inferior costal facet, watch this. This is superior larger one surely for its own rib, and smaller one for the rib that is next to that. And if this is for example its own rib, so this rib's smaller portion, this comes from the preceding one. So, here will be for example, if it is a fourth, so this will be for the fourth and this will be for the fourth, and here this will be from the third vertebra, and here is the fifth, and fifth has got larger here. So, this will be for the fifth, and here this will be for the fifth rib. These inferior costal facets. So, in the body you should know that its articular surface for the intervertebral disc above, intervertebral disc below, and it has got these two articular facets as a costal facets. Then we have already told you this green color, this is called the pedicle, joining the vertebral arch with the body here, and body has got this, you see already, superior costal facets. These are called the pedicles. Now, after the pedicle, you see after the pedicle neural arch comes, and in the neural arch the major portion is this. You see, this is the major portion, which you know that it is forming the posterior main part, you see posterior half almost of the vertebral foramen, and anterior less than half it is formed here by the body, and sides are formed by the pedicles. So, the bony part of your vertebral canal has been formed here, and inside is lying the spinal cord along with the meninges, and surely blood vessels also. So, you call this as the lamina. You see the lamina comes from left side and from right side. This in most of the cases, almost all of the cases except in the first cervical vertebra, they join together, fuse in such a way, they will go behind, and actually half of the lamina sacrifices itself to become a single structure that will project behind here. This is called a spinous process. If it will not project, you see behind here, so you see that these two lamina will remain very, very large like here, because they are not going behind, but if they will go behind here and form the spinous process, they will become like this. So, lamina will compromise its length, and here lamina, if it not compromising its length, it will open up, so it will become like this. This will be called, this happens only in one vertebra where the spine has to be sacrificed, the spine is not present. This is first cervical vertebra. You will see here a very long, very, very big arch has been created here. This is called the posterior vertebral arch, but this is in case of first cervical vertebra. Here in all the vertebrae, in many you see in all 6 cervical vertebrae, and then in the all thoracic, all lumbar, we have this spine available obviously. This is called spinous process, but this is called the lamina. But the lamina is important in such a way that when the lamina finishes here, from the lamina above, the two processes emerge here, and these processes will have articular facets which will be directed posteriorly. These are called the superior articular processes. These superior articular processes will articulate with the inferior articular processes of the preceding vertebrae. If it is the fourth thoracic vertebra, these two will articulate one on either side with the inferior articular processes of the third thoracic vertebra, and that joint is called the zygapophyseal joint, because these are called the zygapophyses. So, these are the superior. So, in the lamina again important is from their superior limits there will be superior articular processes, and we have similarly inferior articular processes also, but they are not visible here because they are present on the lamina fused on anterior aspect. I will show you this also. See the lamina clearly here. Part of this of the vertebral canal will be formed by the pedicles, and most of it will be formed here by the inside of the body. You see the circle has been created, and here is lying the vertebral column. Here is lying your spinal column. This was a lamina. The spinous process already you are watching. The spinous processes, you see they are pointed and they are oblique here. They are not horizontal, they are oblique in such a way that they will be actually hiding at least 1.5 spines. You see 1.5 spines below even this spine, and when half of this spine will be, means one vertebra and other vertebra half, at least 1.5 vertebra will be hidden by this obliquity of the spinous processes. This is one of the distinguishing feature. This is spinous process, and you are watching the spinous process, and now if you look at this and you are looking at this, because this is body, so this is anteriorly placed. I say it is facing anteriorly, this is facing posteriorly. These are called superior articular processes, and these are called inferior articular processes. This is a inferior articular process, and these are called superior articular processes. Means they both, and at the same time from lamina is emerging your spinous process. You see two processes related to lamina, two processes related to lamina 4, fifth is the spinous process, and a pair will be the transverse processes also. One is showing on this side also. So, 2 superior articular processes, 2 inferior articular processes, 2 transverse processes, and 1 will be spinous process. Means we have got basically 7 processes emerging out of the lamina, and surely anteriorly emerging out of the lamina will be surely the pedicles also, if you count them as processes also. You have 9 processes emerging out of it. And if this is here, so you are seeing here superior articular processes, they articulate with the inferior articular processes of the preceding vertebra, because they are directed and facing posteriorly. Superior articular processes should be directing anteriorly. You see this inferior articular process of the upper vertebra, this will be directed anteriorly. So, this is posteriorly directing, this is anteriorly directing, and they both will make a joint, zygapophyseal joint. And similarly here also, this is inferior articular processes which are facing posteriorly, and here the next vertebra will have the superior articular processes facing posteriorly. They both will be articulating with each other, another zygapophyseal joint here, inferior zygapophyseal and superior zygapophyseal joint you have seen. These are called zygapophyseal joints. And then we have the transverse processes from the side of the pedicle, where the pedicle joins here with the neural arch. Immediately the process emerges here, transverse process, and the tip of the transverse process you can see this green color facet. This is a costal facet. This will give articulation to the tubercle of the rib, and this is the very much important distinguishing feature in the thoracic vertebra, and this will give articulation and forming the costotransverse joint, and this is articulating with the tubercle of the rib, tubercle of the corresponding rib. If it is the 5th thoracic vertebra, it must be the tubercle of the 5th rib, and if it is the superior articular facet, it must be attached here to the 5th rib, but 5th rib's upper smaller demi facet will be attached here to the 4th thoracic vertebra's inferior costal facet. And here you are actually watching this also transverse process. If you have got here a collection of different vertebrae, and if you want to differentiate them and making in 3 groups, cervical and thoracic and the lumbar, just pick them and see their transverse process. If the transverse process has a facet, it is always thoracic vertebra. If the transverse process, I am telling you here, if it is a transverse process has a hole inside it for the passage of the blood vessel, it can not be any other vertebra except cervical. If it is doesn't, this is called the foramen transversarium, the unique feature of all 7 cervical vertebrae. And if it is called the 7th, if we have got it foramen transversarium, it is cervical. If it is got the costal facet in the tip of transverse process, it is thoracic. If it does not have any of these 2, it must be lumbar. And sacrum, you know that already is a single piece, there is no confusion in it. So, this is transverse costal facet, you are seeing here transverse process, this is transverse costal facet for the tubercle of the rib to form costotransverse joint. Superior articular we have shown you here, and the inferior articular processes. And then intervertebral foramen, you see here, if this is your body of vertebra, you have this body, and if you are looking at your body, you see the pedicle is coming from posteriorly. If the pedicle is coming from posteriorly, pedicle is actually attached to the body in such a way that is occupying or is attaching and using only the part, you see hardly 50%. You see here, hardly 50% of the body, and 50% in such a way that from its upper limit, this 10% there is no attachment of the the pedicle, this 10%, and this 40% is also no attachment. So, similarly here also, here it will be 10% and here it is unoccupied 40%. Mean this portion is actually occupied, but this portion is not. If this portion is not, so this 40% of your for example, this is T3, 40% of your upper, that is the T3, and 10% of the lower, this will show you here a big hole. This is a foramen between the two vertebrae, in which the bodies of the upper and the body of the lower. More portion will be the upper and the less portion will be contributed by the lower. This foramen is called the intervertebral foramen. And this intervertebral foramen, if your spinal cord is lying in the vertebral canal here, for example, the spinal cord is lying in the vertebral canal. So, from vertebral canal, if the spinal cord is giving the roots out, the roots will actually emerge from the intervertebral foramen, and they will become outside mixed nerves. This is called the intervertebral foramen. So, intervertebral foramen, you see a part of I say larger part comes from the upper vertebra and smaller is coming from here, and obviously some portion will be bounded here by the intervertebral disc also. That is why the herniation of the intervertebral disc or a leakage of the nucleus I say pulposus will lead here to compression of the nerve roots here. This is called intervertebral foramen. And you are watching the spinal cord here, and you are watching here nerves are emerging, and you know already that the intervertebral foramen lies in the intervertebral foramen the dorsal root ganglia also, and here in the intervertebral foramen the sensory and motor roots they combine with each other, join to form a mixed nerve which immediately splits outside into the anterior posterior rami, a very long anterior ramus, a very short posterior ramus, and the anterior rami usually going to the limbs, they mix up to form the plexuses. Then is the vertebral canal, already we have told you that, anteriorly bounded here by your inside of internal aspect of the body, posteriorly bounded by the internal aspect of the two laminae, besides by the pedicles. A foramen is created, this is called the vertebral foramen of this vertebra, and then vertebral foramen of the next, and next and next, you will see it will all will be vertebral canal that will continuously will extend, you see it into the sacrum, and here it will be called as the sacral canal. This is spinal cord line inside it. How to distinguish the vertebra, thoracic vertebra? I have already told you, thoracic vertebra you can distinguish it in such a way that they have the facet in the transverse process. Spinous processes, they are more pointed and oblique also, you see they are oblique in such a way that they will be actually covering 1.5 even the next vertebra. Body of the thoracic vertebra, it is a heart shaped, and the bodies have inferior and superior I say articular I say costal facets. These are very important distinguishing features here. Body you are watching, this is a heart shaped body. Facets you are watching, pointed oblique facet in the transverse process. So, these are the distinguishing features which you will see. Herniated disc, already we have told you. This is the annulus fibrosus, crack, and fibrous tissue as a nucleus pulposus comes out, and it will compresses the nerve roots. Various parts of a disc you are actually watching here. Let us start with another component of the thoracic cage, that is the ribs here. We have 12 pairs of ribs, 12 pairs of ribs which are anteriorly connected to the sternum and the Manubrium sterni, body of the sternum and Manubrium sterni, and posteriorly they are having joints at the different places with the corresponding or to the adjacent vertebrae. So, these 12 pairs of ribs behind vertebral column comprising of 12 thoracic vertebrae, and in front is the breastbone, that is the sternum, they constitute here the thoracic cage. Now, if for example, you see here, as far the ribs are concerned, you can say they are different types of ribs. If you look at this, one rib group is called the true ribs. These are those ribs which are attached to the Manubrium sterni or to the sternum or the body of the sternum by means of their own costal cartilages. You see this is the first rib, the second rib, the third rib, the fourth, 5th, 6th and 7th also. These ribs are connected to either the Manubrium sterni, the higher upper ribs you see first and second, or the rest of the ribs you see, that 3rd to 7th, they are attached here to the sides of the body of the sternum. These are called the true ribs. You call them the true ribs. These are the true ribs, you see that, because they are attached to the Manubrium sterni or the sternum by means of their own costal cartilages. These are the true ribs, you call them, or vertebro-sternal ribs. But there is another group also, you see there are next ribs, you see next 3 ribs here, 8, 9 and 10. You see this 8, 9th and the 10th. These 3 ribs, if you look at them, they have their costal cartilage surely, but they are not directly attached here to the sternum, but they are attached here indirectly via the cartilage of the rib above them. You see, this will be actually here, you see this is your 8th rib. 8th rib is not directly attaching, but is attaching via the costal cartilage above them, above their rib. Means if this is 8th, so it will be attached here not to the sternum directly, but indirectly through or via the costal cartilage of the 7th. 9th rib through the costal cartilage of the 8th rib. 10th rib through the costal cartilage of 9th rib. So they are not actually attached directly to the sternum, but via the cartilage of the rib above them. These ribs are called the false ribs, or you can call them vertebro-chondral ribs. Chondral means the cartilage is called the false ribs. So these are called the false ribs here. So rib number 8, 9, 10 is the false ribs. But we have now, you can say these are the 7 ribs you have already seen, true, 3 you are watching here, the false. Next 2 you see that to make them 12, these are the floating ribs. Floating ribs are simply call them vertebral ribs. These vertebral ribs, they do not reach the sternum, neither they reach directly nor indirectly, but they are actually embedded within the abdominal musculature. They do not actually come too much anteriorly, they stop almost laterally here, you see that. Even at the tip there may be even the hyaline or the costal cartilage, but usually they are embedded within the musculature of the abdomen. So the floating ribs you call them, the floating rib you see that's the 12th, 11th rib and the 12th rib, they are the floating ribs. You see this is also here, this is the 12th rib and this was the 11th rib. These are called the floating ribs. So these are 3 different types of ribs you have already watched here. You watch this also is this green color we have seen the 1st, 2nd, 3rd, 4, 5, 6, 7 true ribs, and you see this is here 8, 9, 10 false ribs, and the last 2 you see 12 and 11 and 12, these are the floating ribs. Now if you look at the structure of the ribs here, especially the rib number you see 1st and 2nd ribs, these are atypical, and also if you actually go here to the 10th, 11th and 12th ribs, these are atypical ribs, means they have got a little bit different characteristic features here, which is not present in a typical rib. So if you look at this here, but from 3rd rib up to 9th they are called the typical ribs here. So typical ribs are 3 to 9. So if you will actually study only one of these ribs here, the rib structure is supposed to have been done. Now if you are looking at this first rib, this is the widest and the shortest of all the ribs here. See this here, different from all the ribs. Usually the ribs have, if I actually look at this, the ribs have the superior border, which is a blunt superior border, and they have got a sharp inferior border. They have got the anterior surface and they have got the posterior surface also. So inner surface you can say, inner means from inside they are having toward the thoracic cavity, and this is the surface under the skin. So this is what you call here the external surface, and anterior, or you say internal surface or the posterior surface. Superior we have got this superior blunt border and the sharp inferior border. This is in typical ribs you see. But in case of the first rib, it is totally different. They have, so the first rib, if you actually look at this first rib, you see the first rib has got the inner border and is the outer border. and it is the upper surface and has the lower surface. So, it has upper surface and lower surface, it is the inner border and the outer border. This is not actually present in any other ribs. So, the first rib is important from this point of view. You see, in the first rib, for example, if you look at this first rib, we will come to the first rib later, but we watch here first the various parts of a typical rib. Now, in the typical rib, if you see here, posteriorly it has the head, then you see its neck, head, then you see its neck, then you will watch the angle, you will watch here the body of the shaft, then the tubercle is also there. So, various parts of the rib you will see. The first of all, you will watch here the head here. If you look at the head and see, if you look at this head now, head lies posteriorly, and posteriorly means it articulates with the vertebra. With vertebra, because the head has basically two articular facets. If you look at this head will have the two articular facets. You see, is a larger one will be the lower and smaller one will be the upper. It has the two articular facets, the larger you have seen also and smaller also, and both of them are separated by means of a small ridge of the bone that is called the crest of the head. So, this is called the head, and head articulates posteriorly with the vertebra, and vertebra in such a way that if you have got the two vertebrae, if for example this is now my fourth rib. So, if the two vertebrae are lying there on the back side, you see this fourth. So, this vertebra, it is the fourth vertebra, this is the third vertebra, this is T3 and T4, the third vertebra. Third vertebra, if it is the fourth vertebra you are watching, it has got the superior articular facet, costal facet, and it has got the smaller inferior also. Similarly, here a larger superior and smaller inferior. This indicates that here the head of the rib is actually attached, as a making here a joint. You see, here the head attaches. So, makes here a joint. Because the larger part being the lower, so the superior articular facet of the fourth, because this rib is basically, it is the fourth rib. So, fourth rib, its larger portion will be the superior articular facet of its corresponding vertebra, and this demifacet or the smaller one, it will be accommodated by the lower articular facet, which is the smaller one of the preceding rib here, means the third rib. A joint has been created here. This is called the costovertebral joint. So, this is what we call here the head here, the first part of the rib here. Come to the second part, you see this is the head which you have been shown with having two facets. Neck, another is the part which is not too much remarkable here, but you see that it is also a small flat piece of the bone that connects the head of the rib, this one, with the shaft of the rib here. This is the shaft of the body. Means the head and the body of the shaft, they are connected by means of this small piece of the bone or the small flat piece of the bone. This is called the neck of the rib. So, we call this as the neck of the rib. This is the second part of the rib. So, you are watching here this also, this is the neck of the rib. Then is a very important thing here which contributes in a joint also. At the junction between the neck, you see this is the neck, and the body, this is the body, you see after the neck you are seeing this is the body remaining everything. Right at this junction you are watching here a tubercle, this is called the tubercle of the rib. Now, you see this is the tubercle of the rib, which has got a smooth surface and a rough surface. The two surfaces are there. This smooth surface you are watching and this rough surface you are watching. This is again important here, this one. This is its smooth surface, this is its rough surface. This smooth surface, it articulates and forms here a joint with the tip of the transverse process of its corresponding vertebra. If this is the fourth rib, for example, this tubercle will articulate with the facet at the tip of the transverse process of the fourth thoracic vertebra, its corresponding vertebra, to form here a joint that is called the costotransverse joint. So, tubercle is very important for this purpose, and the rough surface which is actually present other than the tubercle, this is for the attachment of the ligament. The ligament the same, this is called the costotransverse ligament. This is called the tubercle. We will show you that in the joints also. And then you are watching this also, tubercle, smooth surface for the articulation with a costal facet at the tip of the transverse process of its corresponding vertebra, and then this will be its rough surface for the attachment of a ligament that is called costotransverse ligament here. This was the tubercle. Then is the angle. After the tubercle, you see after the tubercle and its attachment of costotransverse ligament, there is a sharp curve. This curve is called the angle. Angle of the rib. Angle of the rib, you see, it is the most, I say, weakest part of the rib is the angle, not the neck even. This is the most weakest part, and you see, this is the most important part that undergoes fractures in an impact injury, not in a direct injury. In direct injury, any part can be fractured, but in an impact injury, if there is a trauma from outside here, usually the part of the rib that fractures most, it is the angle, or the part a little anterior to the angle where there is a maximum curve. This is called the angle. This is the fourth part of your rib is the angle. You see this green color, this is an angle. Then you come to the shaft. The curve becomes most prominent, you see, at the costal angle, and then this will make here a body, and the body will end here at the last point. You see this body will end here, and here usually you will see that it will be cup like costal, it's a cup like structure. Our body ends into a cup, or with a cup here. You see this will be like you see it is a concavity is there. You see this ends here, and from here will start the costal cartilage. This costochondral junction is this, as a primary cartilaginous joint. This is called the costochondral junction, and this costochondral joint will happens at this costal, this cup here, which it ends here. And in this also, if you are looking at the shaft here, the shaft will have if you see the shaft like here, so the shaft will have the blunt border above, the sharp border below, and it will have you see it will have internal surface towards the pelvic towards the thoracic cavity, and the external surface under the skin and superficial fascia. But if you look at this sharp inferior border, inner or deeper or closer to the sharp inferior border, from inside, if you will actually feel, you will feel here a groove. I am giving here a broken line because it is lying deeper to that. This groove is called the costal groove, very important, because here is lying the neurovascular bundles here. If you are actually looking at this is called the neurovascular bundle. So it will happen, and you will be actually seeing here the neurovascular bundles are present here. So see, this is here sharp as a blunt superior border, sharp inferior border, and here deeper to that will be the costal groove, and in the costal groove is lying a neurovascular bundles. First will be the vein, means deeper to that will first will be the vein, then is the artery, and the last will be the nerve. So this is in VAN arrangement. So the nerve can even sometimes hangs below the inferior sharp border also. So between the intercostal spaces, if you are inserting the needle very close here to the inferior border of the rib, you might injure the nerve first, and sometimes even the artery can be there, or you can have the penetration, or you say having piercing the artery also. If the artery or nerves, they are not well accommodated in the costal groove, if it happens. So this was the shaft you have seen here. So after the shaft, you see this all 5 parts of the ribs you have seen, their surfaces, borders, etc. They will be very important in the attachment of the muscles. So you look at now the atypical ribs, like the first rib. You see the first rib is the shortest and the widest rib. You have already noted here, difference here will be, it has the inner border, it has the outer border, head is there, but the head will have only one facet, it is not having 2 demi facets here. so that it should actually have a articulation with the body of its corresponding vertebra, means T1, and will also have one demi-facet to get accommodated by the last cervical vertebra. No, it will have just one facet here. So, only T1 vertebra will accommodate it to form here the costovertebral joint. At the same time, the tubercle will have, it will have also the tubercle that will articulate with the T1 vertebra's transverse process tip, the facet forming the costo-transverse joint. This is also important. But as far your thing is concerned, like for example, if you look at this rib here, two very important landmarks which are important here. And these very important landmarks, one of these landmarks is here, these two grooves are there, very important grooves here. One groove which is see more anteriorly placed here, this groove is for the passage, because from here the vein comes and veins will go here over this here. This is the groove for the subclavian vein, and after that more posteriorly you will see here the groove for the subclavian artery. This will be for the subclavian artery. So, this is for the subclavian artery. So, there are two grooves and they are separated by means of very small ridge here, but these are the two grooves which you are watching here. So, you see this one groove and another groove also, and these grooves in between the groove you will see that in between the groove there is a tubercle also, and this tubercle is important. Why? Because from the transverse process cervical vertebrae is coming here a muscle, and that muscle gets attached to this here. This muscle's name is the scalenus anterior muscle. So, when it will pull, the first rib will be pulled up. It is not just the first rib will be pulled up, sternum will also be pulled up along with all other ribs. So, the anterior posterior diameter will be increased to give you more space inside for the inspiration purpose. This is for you say in forced inspiration. These muscles are, these are accessory muscles of inspiration. Normally for inspiration diaphragm is enough, but some other muscles will be used also, like this one and some other like the sternocleidomastoid also. So, this muscle is very important, scalenus anterior muscle. Landmark wise point of view, this is also important here. This was about the first rib. So, look at the second rib also. The second rib little larger, you see that and longer than the first. Here again it has the head also, but the head has the two facets. The larger one will accommodated by the superior articular facet in the body of the second vertebra, its own vertebra corresponding, and the upper smaller facet, demi-facet, will be accommodated here by the body of the first thoracic vertebra. Its lower articular facet will be for this purpose. This is just for all ribs also. When the two heads head will have the two facets, the larger, the lower facet in fact will be attached here to the superior articular facets of its own corresponding vertebra, and the upper smaller facet will be accommodated here by the lower articular facets of the preceding vertebra. So, it will get the help of the vertebra above that. Longer than the first rib, I will already told you that. And another very important landmark here is on its superior surface there is one roughened tuberosity here, this tuberosity. This is for the attachment of the serratus anterior muscle. This is important here because all the ribs in fact will give attachment here to the serratus anterior. The serrata, these are the digitations here. So, all they will get here behind to get attachment to the scapula. So, this is second rib you have seen here. Look at other atypical ribs 10, 11 and 12. So, it is 10, 11 and 12. These ribs again very important. In a sense, this is 11th rib you are watching. They have also one facet which will be attached here to the costal facets on the body of their corresponding vertebra, and 11th and 12th ribs already we have shown you. These are the floating ribs and they are embedded in the musculature of the abdomen, and these ribs do not have one thing very important here, that these ribs do not have a costal, I say do not have the tubercles. So, costotransverse joint is not present in the last two ribs, it is present in all others. Even you see this is a tubercle present in your second, tubercle present in your first, but in this last two the tubercle is not present. Now, if you look at the clinical correlations, they are important again. Rib fractures, they are very common. If you look at this here, in children usually the ribs are less commonly fractured because of their elasticity. They have got a lot of elastic substance, elastic tissue in their ribs. So usually they are pliable and they will sustain the stress or trauma from outside, and they do not fracture most commonly. But because they have elasticity, so chest wall will become a thoracic cage. In children it will be more pliable. So chances are that the organs which are inside will be less protected. If the injury is from, or we say trauma is from outside here, the child can survive injuries, but due to the elasticity, the ribs can be pressed inside here and they can cause the damage to the underlying organs like the heart and the lungs, and also some of the abdominal organs which are lying under the ribs also, like the spleen, the liver, these can be injured also. So, in children they can survive, they can sustain the injury and they can survive the fractures, but due to the pliable structure of the chest, they can have their important vital organs having some problem here. Again, but with increasing ages, with the increasing age, you see rib cage becomes more rigid. Why? Because of the deposition of the calcium in the costal cartilages. So, they become more rigid here, because these, even the costal cartilages which are hyaline cartilages, they undergo even ossification with the advancing age. So, they become more stiff now, more stiff with the increasing age, they become less pliable, more rigid they are. So, chances are that they are brittle now. The ribs then, and I have already told you that the weakest part of the ribs, which usually fractures most, is the most interior, I say interior part of the angle, or you can say the angle of at the angle you see where there is a immediate curve is there. You see that the angle of the rib is the most important, the weakest part and the brittle part of the rib is this. And here especially you see the middle ribs here. So, from 5, 6, 7, 8, 9, so middle 6 ribs especially, they are see from 5 to 10, you can say from 5, 6, 7, 8, 9, 10 means 6 ribs, they are most prone to get the fractures here. The reason, because they are less protected. Upper 4 ribs, they are more protected, especially the first rib, you know that this is under the cover of the clavicle. So, it is protected, natural protection. Then the second, third and fourth ribs, because they are under the cover of the pectus major muscle, very thick and bulky muscle here. So, they are protected also. But the lower ribs, they are here, like I already told you, these are less protected, that is why they are most commonly fractured here. And because even the 11th and 12th ribs, because they are the floating ribs, they move with the force of the impact, usually they are also saved, because they move with the earth, because they are flexible, they are movable, because they do not have a joint anteriorly with the sternum. That is why with the impact of the force impact they are moving. So, because of this flexibility they survive. So, the middle 6 ribs, they are having a problem, upper 4, lower 2, they are usually saved, because you know that here this is the thoracic cavity inside visible here through the intercostal spaces, and ribs have the outer surface covered with the skin, again a somatic structure, and inside they will have inside the lining of this cavity inside will be, if for example you are watching in this, for example we have got here the skin, then superficial fascia. Thorax does not have the fascia. Immediately you see there have got the ribs, then rib, and between the ribs there are the muscles also here. Then you have a fascia, that is called the endothoracic fascia, and this last will be the pleura, that is called the parietal pleura. Parietal pleura, and outside is the skin. So, that means your ribs are is sandwiched between the skin outside and the parietal pleura inside. So, it is sandwiched between it. So, that means there are a lot of things here, it is not just the ribs only, but there are many things here. So, here outside it will be the skin, and inside it will be very thin layer, that is called, so inside it is a parietal pleura. And outside it has the skin, and between you have the ribs. So, if for example, if the ribs fracture, so the jagged ends or the fractured ends can be protruded inside here and can cause the rupture of the pleural, I say rupture of the parietal pleura. And because this is parietal pleura and inside is the visceral pleura, there is a space that is called the pleural space. So, if there is injury from outside, so the air from outside can rush into and will fill this space. This is called pneumothorax. Why the pleural space is opened here? The reason is that because this jagged ends of the fractured ribs cause the rupture of the parietal pleura. Means the rupture of parietal pleura is there. So, you see inside we have got the visceral pleura and this has been opened here. So, air from outside, obviously there is a cut in the skin also, with the pressure the air enters inside and this space will be filled here, positive pressure and lungs cannot expand. This is called the pneumothorax. Because these are the ribs. Ribs are the flat bones. All the bones, usually all the bones which are covering and forming the cavities, usually they are the flat bones. The skull, it has the calvaria which unite together, the bones unite together to form the cranial cavity that supports and protects the brain. These are the flat bones. And again here you see is forming the cavity, this is called the thoracic cavity, these are the flat bones. And flat bones and these are the bones, and bones they are covered with the periosteum. So, this is here, and when there is a fracture, there is a breach in the periosteum, you see, which are innervated by the intercostal nerves. Intercostal nerves means this is a rib and another rib. So, we have got here rib also. So, these are the intercostal spaces. This is intercostal space, this is this intercostal space, these are the ribs you are watching. So, it is intercostal space, so nerves are lying here also, nerves are lying here. So, this periosteum is getting the nerve supply from the nerves from above, nerves from below, and there is a lot of nerve endings here. So, when there is a breach in the periosteum, it will be severely painful. And to encourage you see the patient to have, and so this will affect the breathing also, because he will be scared of having proper breathing, because when he will breathe, movement will take place here, periosteum will be disturbed and he will feel severe pain. So, he will check his respiration. To relieve the pain and to encourage the breathing, the nerve block is done here, because intercostal nerves should be blocked. I will tell you later in the intercostal nerves, this is called intercostal nerve block here. And if for example, because lot of vertebrae, they are a lot of your ribs are there, and because if these are the ribs here, diaphragm is like a dome. So, the structures which are in fact present under the diaphragm, they are under the cover of the ribs also. So, if for example, below the nipple, if there is an injury, this will lead here to the injury to the rupture of even of the liver, or under the 9th, 10th and 11th rib there is a spleen. So, a spleen rupture can take place also because of the ribs. Fracture ribs will lead here to this problem also.